So COVID-19, let me just go through a few details before I can hand it over to Darshan. So I would first of all welcome everyone to the second webinar of the series from Dental Routes. It was nice to know everyone enjoyed the previous webinar on oral surgery. We had a lot of wonderful feedback. Thank you guys. However, I just want to mention there was a few hiccups in the website in terms of downloading certificates and things like that. They are looking at it very, very seriously just because of this mad rush everywhere about software and servers and things like that. There's a few issues. They're sorting it out. They are going to be sending you links as soon as that is sorted out for you to download your certificate. So you don't have to worry. We are on top of it. And going further, today we are discussing about the coronavirus and the important facts we need to know as dental professionals as we are getting ready to go back to work. And I hope we are. So just fingers crossed. We thought, what better way than have a discussion with our colleague who is duly qualified as a dentist and a doctor. He has a great passion in research and training. And this man has volunteered to work in the front line. Contracted COVID-19 while he was working. He went through all the horrors of suffering the consequences and has come out more wise on the other side, if I may say so. Yeah. So let me take no time now to introduce the wonderful man, Dr. Darshan. He's, as I explained to you before, he is duly qualified. He has done his dentistry first, then he went on to do his medicine at Bath's Royal London. He later on went on to do his master's in implantology as well. He enjoys teaching, so he lectures at the FGDP. He mentors a lot of upcoming dentists, implantologists, and oral surgeons in London and surrounding areas. He works in a lot of referral centers as an oral surgeon, and he has a thriving private dental practice in London as well. The list goes on, so I try to concise it as much as I can. And actually, to give a bit of a gist of why we picked up this topic today, I actually spoke to Darshan about 3 days after the lockdown. That's probably, we had a lockdown on the 23rd of March. And 3 days later, my call was really because I was worried even to get out of the house at that point of time because of all the stories that I was hearing from everywhere. And when I called Darshan, this man was getting ready to volunteer and work in the hospital. I was like, man, this is crazy. And we have followed him since that time. So it is an amazing tale, which we can explore as we go. So let's get started here. How are you doing, Darshan, today? Are you doing okay?
Thanks a lot for your introduction, Kaushik. I always say that you do a lot better than I would ever do at saying some things about myself. But yeah, no, I'm doing very well now. Thank you. All good.
You deserve it, man. You deserve it. So let's get on with this. So yeah. You tell us. So let us know what was going through your mind during those initial period of lockdown when you decided to go and work in the hospital. What was that was going in your mind, Darshan?
It was a very simple thought process. I mean, I couldn't say it very differently. From a dentistry point of view, I think a lot of things were shutting down. We were aware of a lot of restrictions being placed on procedures that we could provide. And eventually we were told to shut down all the clinics and only working in the UDCs. I had a background of working in maxillofacial surgery for a long period of my career. And I had kind of worked once or twice a week there before, right until 2016-17 time. So I found it pretty easy to want to go back and work in the same specialty, trying to see how much I could to help. And generally, I noticed that as a community, we were beginning starting to work as one and trying to control the effects of the virus. And I thought I could do my two bits by trying to go back to the hospital and start working in a maxillofacial unit.
Mm-hmm. So where did you go and work, Darshan, during that time?
So I was working in a hospital close in London.
Okay.
So mainly in the maxillofacial unit, yes.
Okay.
Um,
Okay. So when we were sort of getting all these mixed messages during that time, what we were sort of looking at was these issues with PPE and all those things. Yeah.
yeah,
But you are a role model, man. You are a role model. My respect is with you, Darshan. We were actually sitting at home looking at Facebook and other news platforms. We're consistently bombarded with information about lack of PPE, lack of hospital staff, huge influx of patients, etc., etc. So when you went into the hospital, so what was it that you experienced with regards to PPE and the level of care and services that was provided to the patients?
yeah. I mean, I guess it varies a lot around the country. I couldn't speak for everyone working around different parts of the country in different specialties. But to kind of share that with you, I put up something on the screen. I wanted to give them people an idea to see these are the kind of masks that we had, the FFP93s or the N99s, which basically says there's a filtering face piece particles, and the N99 tells you that 99% of the fine dust particles, because that is what these masks were initially started off for, to work for in work environments, construction industry, and 99% of the particles would get filtered. That's what the type of mask we were using. The fit testing was provided with a person who's officially qualified in providing a fit test, and it involved getting a good amount of seal on the bridge of the nose and also on the bottom of the chin to make sure that there was enough, it was snugly fitted for you, that you couldn't smell a fine spray of aerosol. So this is the test kit, similar to what we were using. And that test kit was allowing us to understand how well the mask fitted. Also, the visors provided were slightly different to the ones that we use in dentistry. And the visors were ideally had a thick styrofoam or sponge that was adapted quite closely to the forehead, unlike the visors that we were using in dentistry, where the visors near the forehead there's a big gap. But obviously this was before COVID times. And the plate, the mask, the front of the acetate plate comes down right below the level of the chin. You had a head cap on, and then there was a gown that was fitted on that you'd wear on top. And depending on what procedures you were providing, you could also wear a plastic apron on top of that. Obviously, we all had scrubs that we were wearing underneath. So that was pretty much the kind of PPE that we had. And I thought that was a very good level of PPE. The morale in general was very high in people who were working in the hospital. And they realized that they had to up the ante, which they all did very, very well. And also, I thought that it was good to kind of, for me to go back and meet the old team that I used to work with before. And it kind of allowed us to settle in. But again, I didn't spend too much time there, to tell you the truth, because I got infected quite soon. And it was very, very difficult to tell as to where I even had the source of the infection from, because the incubation period can vary from 5 to 15 days. And I had only gone back for about a week, so it was difficult to say.
But do you, reflecting back, we do understand that it just came in from nowhere, and it was very difficult for anyone to be ready for a situation like that. Yeah. What you're explaining me and what you experienced working at the hospital, you countering COVID-19 yourself, is this an appropriate amount of PPE that we should be happy with? Or because some of the videos I could watch was probably much more intense in the way the PPE was sort of used. Yeah. What is your thoughts there?
So, I mean, from the late part of March, early April, to the middle of May that we are at, I think we've learned a lot. We have learned a lot about the virus. Yes, it isn't a big period of time, but with the way that we're working from a frontline point of view, people have learned a lot of lessons. There's also other countries who are slightly ahead of us, from the phases of their infectivity and infections. So you could also learn from other countries in Europe and even further down east that actually the PPE level had to be upped because the virus is a lot more contagious than what we understand it to be. And it also presents in very different ways, which we will be discussing as we go along. I'll be discussing that with.
Well, what about these ventilators, Darshan? This is the word that I think was Googled the most during these last 2 months. Yeah.
Yeah.
So what is it, and why did we have so much of shortage of these ventilators in the country when we needed it the most?
Yes, I mean it was a difficult one to understand initially, I guess, for many people. To give you an approximate idea, because I don't want to go on into a lot of details about ventilators, but I'll give you some input into it so that we know, because we've discussed it, people have talked about ventilators so much on the media, especially in the beginning. So the ventilators, in a nutshell, is a machine that breathes for you when your respiratory system starts to fail. So it pumps in oxygen into your lungs, and it pulls out the air, so it expires the air. The expiration is done by the machine. It pulls out the air from the lungs of carbon dioxide as well. Sometimes it assists completely, where it takes over the function of inspiration and expiration. And sometimes when the patient has got a weak breathing reflex, then the machine works with the patient and allows them to breathe better. But ventilators are something that is used in a much later stage of respiratory failure. In the initial stages especially, what the hospitals tend to try to do is use oxygen with the help of humidified or with a lot of water vapor. So it's heated water basically, along with the oxygen, and that allows a lot more oxygen to be delivered to the patient's lungs. That's one way. The other one word that we would have probably heard a lot on the news as well is proning. Proning is as pretty much what it says. You turn the patient onto their stomach, so that somehow was allowing the uptake of oxygen and air into the lungs. So by increasing the humidity and the oxygen at the maximum oxygen flow and proning, patients were still being managed without actually being ventilated. But once this doesn't work and your saturations keep dropping, then the ventilator would come into play. And as you see in the picture here, is a tube that's put straight into the trachea from the mouth. And there's a cuff at the end of it, which is inflated. So it creates a seal. And then the machine then pushes air in, which can be enriched with oxygen, and then breathes out for you, as I explained before. So ventilators are ideally used in theaters when patients are asleep, so under general anesthetic. And they're also used in ITUs where respiratory failure happens. So therefore, there's a sudden, with patients who are having a lot of respiratory failure with COVID-19, it obviously was something that was very much in the media. So I hope that's it gives you a clear picture about what.
Yeah, absolutely. And then for some of us, for the people who have joined us a bit later, before I could do the introduction, actually Darshan has a dual qualification, so he has a good background of medicine as well. And I thought it is very sort of nice for us to get a good feedback from someone of his stature, and which also is relevant for my next question that I wanted to ask Darshan, because I think we need to have a better understanding of this virus going forward before we start working, because we are going to be one of the professions which will be massively affected by the overall impact of this situation that we are going through. So saying that, let me come to this. It's a very important issue, and that is the virus itself. We were of the opinion that the elderly and the people with underlying conditions, those are the ones who are getting affected. But Darshan, you were explaining me how even younger people and people with no underlying conditions are being affected by the virus. Would you please elaborate on this for us so that we can understand what is this virus, what is the way of spread and its mutation capacity? I wish we humans could adapt as well as this virus, man. So please tell us about this virus, Darshan.
Okay, so what I'll do, I mean, I'm not an expert on the virus personally, but I've done a lot of research, especially after sorry, after falling ill myself. So reading about the virus has given me a lot of information. And then there's a lot of new publications that are coming out all the time. Every day you read a new publication that's come out. But what we have to understand is that we are in a very fluid environment right now regarding the virus, and we don't really know that much about it because it's only been around for 4 or 5 months overall. So the amount of information that we have is quite limited. On that basis, I would say that we are starting to learn a lot more about the virus as time goes on. And it's something that I will try my best to explain to you today. So from that point of view, let's give it a small start and talk to you about what's, so here we've got like the last 4 to 6 months, we've heard about COVID. It's really affected our lives quite significantly. As I said before, much is still uncertain about how if exactly it affects us, but there are certain theories around it, and this is based on the previous viruses that have been around, like the previous SARS viruses, although not really related to the Corona-19 virus. There is still some kind of cross-understanding that a lot of the experts have been putting together. So now you've got approximately 1 million infections. And in the UK alone, we've got almost 35,000 deaths. I might find that the numbers have increased tomorrow or the day after. So that's why I use the number to kind of extrapolate exactly what's happening in the country. Okay, so let's see what we can cover today. Sorry, Kaushik, were you trying to say something?
No, fine. Yeah, that's a big number. Yeah, carry on.
It is a big number, yeah. So let's try and look, what we thought we'd learn today is to kind of get an understanding of what COVID-19 is, how it presents clinically, and some explanation as to why it presents that way. You were asking me before how there's a varied presentation between patient to patient, and some people are fit and healthy, some people aren't. How is it going to affect certain people and others? And then how is it going to affect us as a profession and personally as people who work in a high-risk environment, potentially a high-risk environment is what we're talking about. So any virus is just a thin protein shell which has got DNA or RNA in it. Majority of them are RNA viruses. This particular virus can be called as a rhinovirus or a virus that comes up mainly in the nose. It was first seen and presented in chickens and then also in humans in the 1960s. It presents with symptoms like the influenza and a cold. And when it was looked at, the reason why it was called coronavirus is because of the way that the top of the virus looked pretty much like the rays of the sun coming out from the sun. But corona also means crown, but it also means the top of the sun. So it can start as an upper respiratory tract infection, hence why the word SARS, which means severe acute respiratory syndromes. And then you get upper respiratory tract symptoms, which can go down to the lower respiratory tract. So it can affect other organs in the body as well, as you can see. And as we're learning more, it does tend to infect or affect other parts of the body as well. Then you can get, the reason why we talk about it so much and why it is so effective is because it spreads in many ways, not just by contact, not just by droplets of fomites, but there's indirect contact or fecal route, something that people have talked about, and conjunctival presentations have been seen recently, especially in children and also in some adults. Right, okay, so that's the basic structure of the virus, hence why you can see the name. It does look a little bit like the sun and the sun rays. These spike glycoproteins is what the virus uses to adapt onto the lung tissue once it's entered there. And that's where it eventually starts from. It's got the RNA from the inside. And then that red part is the protein shell that we were talking about. So it's actually a large virus in relative terms, but it is very, very small. That's why it is so easy to carry, and so you can pass them on in large numbers. Right, okay, so I need to understand a phenomenon called zoonosis. Why? Because I thought I wanted to give you an idea as to how the virus actually does spread. Again, there is a lot of theoretical understanding behind this. There is no very clear 100% sure about where the virus has come from or how it is infecting people. But as I said before, going back to what we learned before and from history, and also from where the virus can be isolated, mainly from bats, you know that they had to have this virus had to have the ability to be able to jump from one species to another, and that is what we're looking at. And it can be a direct jump. So, for example, if you take our understanding is they come from bats, and if they're coming from bats, do they come directly to humans, or are they using an intermediate vector like the pangolin or the camels, or even a civet cat has been thought to be the vector. But just yesterday, I was reading about I was reading a paper where the pangolin virus, it has about 90% or 95% RNA, what do you call, similarity, but that's not, apparently we don't have enough evidence to connect it to that. So we really don't know, but this is our understanding of it. So the original species of the virus normally evolve together. So for example, the bats have the coronavirus, and they get a cold, and then they get better. It's like you and I getting a common cold. And we improve as we take a few days of feeling unwell, and then we get better. But when there's a lot of close contact between a lot of species, which are, which is perfect, is a perfect environment, for example, in a wet market, where the animals are all alive, they're in huge numbers, stacked on top or stacked next to each other, and humans are constantly contacting them, then these viruses can then jump from one species to another. And the thing is, once one species has the virus for a while, and their immune system evolves with them, that time that that particular species uses allows their immune system to evolve with it. But when the virus jumps onto a new species like us, and our immune system is not aware of this virus, it hasn't read it before, that's when suddenly we start getting infections. So this is what we were looking at. I just added that last bit at the bottom at the rest of the day. At the end of just this morning, because of what I read, because I wasn't sure, it was not nice to blame the pangolins for it if it wasn't from there. So, but we do know that the virus is originally from bats. That's that much of information we do have. Whether it will change or not, we don't know. Whether it came straight to us, or it came through a camel or a cat, or a civet cat, sorry, or a pangolin, is difficult to say. So that's this is kind of the understanding of what we have regarding the virus so far. Okay, let's go back in history very, very quickly. I mean, it's not, I don't want to dwell too much on the slide, and some of the information can be quite difficult. I mean, you can go back to the 19th and the 18th century as well, but I stuck to just the 20th century to give us an idea as to what's happening. In 1918, we had the massive Spanish flu, as it was called, but I don't think it was from Spain. What had actually happened was, during World War I, most of the countries in Europe were involved in the war. This is what, and Spain wasn't. So therefore, they could concentrate on what was happening inside the country, pick up on the fact that there was a very peculiar chest infection, pneumonia-like symptoms that were occurring in patients. And they were the first ones to report it. And hence why the word Spanish flu fell onto it. There were a huge number of deaths. Obviously, that's a very big variation in numbers, but data collection would have been probably slightly difficult then. And medications and hospitals and medical supplies and medical knowledge would probably have not been up to mark just after World War I, II. So therefore, the mortality rate was significantly higher. We then go on to the H2N2, Asian flu virus, which then started somewhere in a Chinese province, pretty much similar to a wet market scenario that might have started it. And then you had a higher number of deaths. Obviously, the mortality rate has decreased, and that could be directly looking at the improvement in medical supplies and treatments. And you can see the HIV virus that we talked about has got a very big time, but obviously with the HIV virus, now we do have retrovirals that are controlling it. And more recently, we've had Ebola and also the Zika virus, which I haven't put down here, but is definitely something to be thinking of. So these kind of history teaches us a lot of things. And here you can see that swine flu was a virus from the pigs, yeah. Bird flu, which was earlier on, was from avian flu virus. So you can see how there is a jump from species to species, and that is when you normally tend to have a situation of a pandemic. Okay, fine. Right. Now that I've gone through the history, is there any questions anybody has got or anything come up, or shall I just carry on? So this is quite an important topic for dentists and our profession as such. Viral loads and cytokine storms is something that I want to spend a little bit of time on. Any questions or anything that's come up at all? No, nothing as yet. Okay, fine. Okay, let's start off. So why are viral loads and cytokine storms important to us from our profession? Well, we ideally work in a high aerosol producing environment, which makes us very prone to getting or being exposed to a lot of viruses generally, or bacteria, with the amount of aerosols, with close contact with patients, looking into patients' mouths, does allow a good amount of infections to spread across to us. In patients who potentially have got corona, and then a dentist works with them with a very minimal amount of PPE, what you get is an invasion of the virus from the production of the aerosols from the handpiece, or from a sneeze or a cough into the air. And what happens is that viral invasion, as it enters your upper respiratory tract, goes and settles in there, and then multiplies in very large numbers. So how we know about viral loads normally is by taking a throat swab, and you check the number of viruses that is there. So this viral load is quite important for us to understand, because the amount of virus that you actually take in and the number of inhaled viruses or the number of contacted viruses does tend to affect a person who takes them in, because once the viruses are multiplied, and they multiply in very vast numbers, there's some theories to say that one becomes a million in about 6 to 8 hours, and then they spread via lymphatics to the other organs. They mainly get to the lungs because they don't have to use the other circulatory systems, and as they go further into the lungs, they use the the angiotensin converting enzyme receptors, to which they attach to, and then invade into the lung tissue. In someone who works in high infective environments, like dentists, like frontline workers, nurses and doctors, and people who contact sick patients all the time, because we naturally encounter a lot of viruses and bacteria, our immune system tends to be quite primed, in the sense our immune system is quite awake and is quite ready to attack any external organisms that infect us. And because of that, you can get something called a cytokine storm, because of a primed, ready to fight immune system. What the immune system does as soon as you get infected is it releases a cytokine storm. So a cytokine storm, it does affect patients quite significantly, because what it is a hyper-inflammatory response, and that's quite an important word to remember. It's a hyper-inflammatory response, whereby inflammation in our body is generally quite good for us, going back to, I think, our second year and third year of dentistry, where we studied about inflammation as a response to injury and as a response to secondary infections, because the inflammation helps fight infections for you and also to help repair tissue. So in this situation, a hyperinflammation happens when the virus enters the body, and then there is a high level of pro-inflammatory cytokines that are released. So tumor necrosis factors, interleukins, granulocyte stimulating factors, and several other chemokines are produced at very high levels. So once they are produced, and there's a lot of other antibodies that are produced, as you can see here from the B cells, the beta cells, and then you tend to get that level of hyperinflammatory response all over the body, which is a very high fever, which is a very common symptom in most patients who have this kind of cytokine storm. They tend to get very high fevers, dry cough, dyspnea because of the inflammation of the alveoli, and sometimes because of all the antibodies produced, you can get sensitivity of the gastrointestinal tract, diarrhea, and nausea are very, very common symptoms. Again, the presentations is so variable and so different in patients that is difficult to say, but it then moves on to continue to give you higher fever. It can then develop into pneumonia, diarrhea, and all these antibodies and all these inflammatory responses, which have to run through the infiltration in the kidney, can then lead to renal failure.
So in that context, how do you sort of explain what is the kind of cytokine load in different individuals as such? So is there a difference from one person to another person on how they react to the virus?
Yeah, so for example, in patients who have a very high a very high sensitive, very alert immune system, so these are your supposed fit and healthy patients, then tend to get a huge viral load from the way that they've been exposed to it, i.e. a very sick patient coughing into the air or contact onto a surface where there were a high number of viruses in the spore mites on the surface, which is then contacted to your nose or eyes. Whatever the reason for the high level of viral load, that directly causes high cytokine storm in patients who are otherwise fit and healthy. So that's why you see that a lot of patients who are healthcare workers or us could potentially provide that certain perfect environment to create cytokine storms in us.
Okay. That's good. Yeah, that's perfect.
So we also know about other viruses, really. There's the the viruses that we always learn about is these three. This still in history, dentistry wise, these are the viruses that we always ask patients to be very aware of. We take medical histories based on these viruses. We also ask about. We also are checking the immune status for patients who've got who had vaccines for hepatitis B. Sorry, not patients, colleagues, our colleagues, working colleagues, because of the fact that you get exposure to these viruses in our regular life. Yes, they do compare, like for HIV, for example, we've got the retrovirals, so therefore we can control the disease quite well. We know exactly how it is transmitted, and therefore we worked very well on preventing and controlling it. And despite the fact that we have a number of cases who are HIV positive around the world, a majority of those patients do enjoy pretty much a good quality of life based on the retrovirals that they're on. I know it's not the case in some countries because the medications are difficult to get, but generally that helps. So hepatitis B and C, you know that hep C is a lot more infective, and also all infected cases tend to get very severe liver issues, a higher percentage of them, while hepatitis B, a lot of patients can be infected but not show symptoms for a long period of time. But we've got a vaccine, and we try and work really hard in trying to prevent hepatitis C by constantly checking on it. And you've got the other viruses that we've talked about before, which again don't really affect dentistry in the UK as such, because Ebola virus was not a pandemic after it was controlled quite well, and the Zika virus is something that's transmitted purely by mosquitoes. Okay, so let's now.
One of the panelists, one of the
sure,
as Dana Parker, she's asking that are you implying that if your immune response wasn't so primed, then we wouldn't get a reaction as hard as what you're explaining.
See, there is. I can see what she's asking. It's a good question because normally, what we are trying to say is there's fit and healthy people do not have any problem. It's the old the people who are older and they're the ones who get the infections and there's a higher fatality rate, and that is generally true. But what I was trying to talk about here was people from the healthcare professionals like you and me and her. So we're all working in an environment where our immune system is primed, and it's one of the reasons why we think that healthcare workers in the hospital are having more symptoms or more cytokine storms secondary to their active immune system. That was my. I hope that's a reasonable answer. I'm happy to discuss that a bit more.
Yeah,
because I can see
I'm
that.
going to be coming to that as we go.
Yeah.
So you were talking about the symptoms and signs. Sorry.
Yeah, sorry. So I mean, we all know that fever is one of the main signs and symptoms there. You've got gastrointestinal and ophthalmological symptoms that have been added more recently, and in severe cases, you get the acute respiratory syndromes, and then you can get lots of disseminated coagulopathies as well, along with the PE. But generally, these are the symptoms that patients are getting: a dry cough, shortness of breath, and the shortness of breath can vary a lot from patient to patient. I mean, I personally didn't have much of a shortness of breath when I was at rest, but on slight exertion, I was getting dyspnea. And then hypoxia, whereby you can check with a pulse oximeter if you've got one, and you tend to find that there is the saturations tend to be quite low despite normal breathing. Neurologically, a lot of patients tend to get headache. Most important symptoms are severe malaise, which is extreme weakness and tiredness, with the myalgia, where you get extensive muscular pain, which is very generalized, arthralgia, and sometimes arthralgia is joint pain, pains along the joints, and dizziness. These cardiovascular symptoms have been added on slightly later. Patients with palpitations, so you could see that a lot of symptoms of palpitations and arrhythmias developed, and there were no other symptoms present, so these classical symptoms were not present, and some patients tested positive to COVID-19. So then there is this understanding that the virus does cause significant myocardial injury that patients and doctors are unaware of, and that can give rise to arrhythmias on the long runs. But these palpitations are usually reversible. Once the patients start getting better, they disappear. Sore throats and rhinorrhea. Sore throats, again, a common symptom along with fever. And rhinorrhea is just a very runny nose, which is a presentation of any kind of cold or upper respiratory tract virus. So it's a myriad of symptoms, and new things are being added to it as we go along. One of the things that people have added on is psychiatric illness, where somehow it is affecting patients to become quite unwell and generally feeling very low and quite depressed. We don't know if that is a direct effect of the virus or indirect because of the extent of not feeling well or unwell, and the time that it takes to get better.
But the main discussion we had when we were chatting, Darshan, was what was the reason why we have started to see so many fit and well patients with no underlying causes having the virus and having very severe symptoms, as compared to what we initially started. This is where it was mainly affecting the people who are on the elderly age group or having underlying conditions. Can you just briefly explain what could be the reasons behind this?
Yes. So apart from the fact that healthcare workers have a very high viral load, which would be one of the reasons why patients are producing cytokine storms, because it's directly related to the amount of virus that you're being exposed to. But in compared to the general public, who, for example, diabetics, CPD, when we go back and when we learn about implants or extractions or any kind of surgical procedures that we provide to patients, you tend to find that we are always worried about the poorly controlled diabetics, because we know that the blood supply or there's microvascular disease, In patients who are diabetics, long-term diabetics, poorly controlled, also we worry about a very sluggish immune system. We talk about delayed response from the neutrophils to help fight infections. And we do know that patients who are diabetic are more prone to getting infections post-extractions or even bone loss and failure around, from implants. Pretty much the same with smokers and patients who've got chronic obstructive pulmonary disease. In someone who's got an already compromised respiratory system, now you introduce a virus into it, and then you've got issues. So then the viral load doesn't have to be that much, and you do not have to get a massive cytokine storm. And because you're medically compromised and your immune system is going to take a little bit of time to kind of pick up inflammation against this virus, the virus it tends to overtake you and then manages to give you the later symptoms of respiratory depression or respiratory failure, and hence why these patients are slightly more prone to the problem. With age, we just tend to find, we don't exactly know why, but patients over the age of 70 tend to be more prone to fatalities. Men are somehow more prone to the issues, and patients of Asian backgrounds, for some reason, Asian and African backgrounds as well now, tend to be slightly more prone to getting the infection and slightly more prone to fatalities. It might be multifactorial, the reason for it, but that's what the numbers show.
Yeah, but as like one of our viewers, Dan, as I put that question across to you earlier, was pointing out that I found it very worrying on why so many healthcare workers were getting affected. Till now, we always felt that we work on a universal safe protocol, and hence we are all well protected from all pathogens. But something's gone wrong now. Yeah, one of the things that you did explain very well was the concept of we priming our immune system. Why do still people get so affected? Is there any other reason other than this one that makes us more vulnerable? Because it's important for us to have a better idea as we are starting to go back.
Yeah, I mean, to tell you the absolute truth, there's no clear understanding of that. But what we can look at is certain points that might make us more. So if as healthcare workers, we are obviously much more prone to exposure. The rest of the public is at home. They are isolated and they are not being exposed to the virus at all. While the healthcare workers are out, they're going by public transport, getting to work. You work in a high risk environment. So therefore, you're more prone to getting infections. Also, from what we discussed before, we're aware that with a primed immune system and a higher viral load, you can get a cytokine storm and a hyperinflammatory response. Most patients in the healthcare work, especially in the front line, can be of Asian, not really just the subcontinental, but even further eastern backgrounds. And the fact that the work stress has been really high, we do know how stress, pretty much like diabetes and COPD and smoking, stress tends to affect us in many ways, even at microscopic and submicroscopic levels, where your stress patterns and your work patterns can change the way your immune system responds. And so that could be another reason why patients are from the health workers are slightly more prone to getting the problem.
That's good, man. That's good to know for all of us. It's more or less a better understanding for us as we go back.
Yeah.
I'm going to come back a bit to your personal situation for the last 2 months, Darshan.
Yeah.
In fact, you were the one who got infected working a few days into the hospital. Yeah. So can you tell me from your personal experience, what symptoms did you suffer? And then how did you cope physically and emotionally during this time? Just not you, because you had to self-isolate yourself for the next 2-3 weeks, I reckon. And then it had a big impact on your family as well, because the children are at home, your partner and everyone else. It would be good to know how that whole saga was for you. It's a bit of a learning curve for us.
Yeah, I mean, to tell you the truth, I probably wasn't in such a bad situation as some of my colleagues were. I have friends who are, they're single, they live by themselves, they come to work, they go back home, and then one of them gets quite unwell, and he or she would have found it very difficult to look after themselves, cook for themselves. Nobody else can come to look after them, and they have to pretty much manage with whatever symptoms they have. Luckily, I had, my wife is at home with me, and the girls, so it was a little bit more easier to have a small family around you to help. But I'll just run through the symptoms that I had. I mean, it was very difficult to tell exactly, as I was saying, where the source of the infection was, because I was I had just kind of finished working in the clinics not less than a week ago.
Should I,
So
you would have a webinar on this one. You would have marked it down better.
yeah. So what happened was I had a high fever, which kind of came on quite suddenly. I was fine in the early afternoon. I was feeling a little bit unwell. Then suddenly, by the evening, I had a pretty high fever. I had a very mild sore throat. Probably was felt like a little bit of an early start of a cold. And then from the second day onwards, the fever started to get improved slightly. But no, I developed this weird nausea. And again, this probably was the cytokine storming that was happening from day one. And that was was giving me gastrointestinal symptoms. I was feeling quite unwell, feeling quite sick. And I developed muscle ache and joint ache. And I was just not feeling that, that ready to help, that ready to do anything. Just wanted to sit around and, just relax, taking lots of paracetamol and lots of water, just hydrating. And I was trying to take it as easy as possible, couch potato style. But I thought I was getting better on day 5. Ideally, I thought, I'm kicking this virus, things are getting better. And there's lots of papers and other patients who do say that initially, after day 5 or day 7, they started feeling better. And then you're ideally said that you need to isolate for a week. And then if you feel better, you can go back to work. So I was thinking, okay, fine, it was a Friday or a Saturday. I was thinking, okay, fine, I can probably start looking at, going back to work on a Tuesday or Wednesday. And then by the 6th day or the 7th day, the fever started getting worse. And I say cyclical because if every 6 to 8 hours, it was either related to the fact that I was taking paracetamol and the fever was improving and it was coming back, but I could feel it coming back every 6 hours. There was definite loss of appetite. A person like me loves my food, and I couldn't eat anything. When I say anything, I had to force myself to drink some orange juice, and that's pretty much it. And from there on, I started losing a sense of smell. And because of that, I also started developing an altered taste. And I went off quite a lot of foods. And generally, occasionally, on those 2 days, I started developing palpitations that would last for about 15 to 20 minutes. And I had a pulse oximeter with me because I do some sedation work. So I just decided to put it on and see. And the oximeter, my oxygen saturations were never below 94%, but the heart rate was going up from 105, to 110. And it was going up and down. This was me at rest. But that improved actually, literally the second day, the day after, literally that improved. And I started getting better. I started getting this slight shortness of breath, but the fever started improving, and I started losing the appetite. Slowly started coming back too, but the loss of smell remained there. Definitely remained for a long period of time. So the slight shortness of breath, and then I started developing just the feeling of feeling slightly low. I think my mood was, despite the best support from the family, I was still starting to go feeling a bit low, just feeling a bit useless and not being able to do anything at home. And I was starting to maybe go into the initial stages of depression. And I could feel that normally being a very positive person who's very active, I just found that I didn't want to do anything, didn't want to engage, didn't want to talk to anyone. I just started staying in the room and literally did start to self-isolate. And but slowly things started to improve. I realized, because once you have insight into what's happening, it's a lot more easier for you to get over things. The fever started improving. The weakness still remained, but the lack of appetite continued for another week after that. But now 4 or 5 weeks down the line, I'm back to normal. In fact, I'm probably compensating for all the things I haven't eaten. But yeah, generally started to improve. Smell took a long time to come back, as we know when you injure nerves, when you take wisdom teeth out, or you tend to find that they're the slowest to heal or slowest to come back. You say 3 months, 6 months, but no. Luckily, in about 4 weeks' time, my sense of smell was coming back. For example, I woke up one morning, 4 weeks, somewhere end of April, I think, or early this month, and I could smell coffee. And I thought, wow, somebody was brewing coffee downstairs, and I could actually smell it, and I couldn't at all before that. So yeah, it was an interesting thing.
There's
But
a couple of very important questions I think I would ask you at this stage,
sure,
related to what you've been explaining now.
yeah,
One is from Manu. Hello, Manu.
yeah,
So Manu is asking, at what point you got yourself tested? Which day of that sort of symptoms that you explained just now?
yeah. It's a good question, man. Thanks a lot. I see another question from Alka as well. Sorry, I'll answer Manu's question
I'll
first.
respond
Yeah,
first, and then you can.
no worries. Yeah. So I personally, I never got tested, to tell you the truth. Sorry, because at that point of time, there was no need. The discussion was that you don't need to be tested as long as you have the symptoms. You are pretty much treated as being positive. But I went through all the symptoms, so I was pretty sure that I was positive. But there's an antibody test coming out, which I think I should take at some point to make sure that it is. But at that point of time, late March is when I had my symptoms. And at that point of time, there were not much tests going on at all. In fact, there was enough, there was some other colleagues of mine telling me that after 3 days, because incubation can take up to from 5 to 15 days, and you have 3 days of symptoms, after that, you might even test false negative. So it was not an appropriate test to do. So that was one interesting question.
Yeah, but then
Yeah.
Alka's a good question here as well, where
Yes.
she's asking that some of the tests, we are getting this on all the time, are giving us positive test results, and the patients aren't having any symptoms to back it up. What is the theory behind that?
No, that's a good question. The way the virus works, I mean, this is a very important point. Thanks a lot, Alka, for putting it out there. The way the virus works, how it becomes so effective in spreading, is because of its low. It's got this stage where it can use certain people purely as carriers. So about 50% approximately of the infected people will not produce any symptoms at all. And how and why that happens, we really don't know. But these patients will carry the virus with them. They might have mild symptoms, which they have overlooked, or they might not have. So they don't produce the cytokine storms. They do not have this massive level of release of interleukin. So they do not fall sick, but they carry the virus, and they are infected. And that's the main issue here, because testing temperatures when patients were flying in and out of airports was easy to miss out patients who had the virus. And they probably, some patients were actually going to develop the symptoms later because they had the virus in them. They had been infected, but they hadn't yet produced symptoms, considering the fact that there's 15 days still left before you start symptoms from the day you get infected. So you can still test positive. I hope that answers your question, Alka. That's a very good question.
Basically,
But
you're saying
sorry.
there should be a lot of general public out there who are completely asymptomatic but still are being carriers.
And positive and infective, yes. And then we know that out of 10, 5 of them can do that. Yep. 3 will have symptoms and improve, and 1 to 2 will have symptoms worsen, develop SARS, and get respiratory symptoms from there on. Yeah, so that's roughly what the breakdown is. I hope that answers your question.
And there's another question which is asking if you have any knowledge of any antibody tests available, especially for people.
Back to work, yeah. That's a good question, isn't it? Yeah, so in some ways, see, the problem is some people say there's different strains of the virus. We don't know how many strains there are. 2, 3, 5, there's speculations on that. Whether then you have an antibody for every single virus that's out there, or do you only have one for the specific one that infected you, is a question. I think there will be an antibody test available very soon. We've been talking about it, and that should help a lot of people go back to work. But whether they're still they're prone to getting infections, or do you then get parallel immunity to the other one, the other strains, is something that we really don't know about. And there were some cases in, I think, in Korea and in China where there were reinfected cases presented, but we haven't had any, as far as I know. Maybe I'm wrong, but we should check it out to see if there's anyone else, if any patients here have been reinfected. So I hope that is a clear enough answer. But there will be an antibody test coming along very soon, as far as what I've heard.
You explained that so well, Darshan. I seriously feel we should get a fellowship on coronavirus now. Dental Routes is listening to my comment here. So going further.
As I said to you, this is such a fluid situation that our understanding of the virus changes every day. So day after tomorrow, somebody might come around and say to me, hang on a second, Darshan, whatever you said is wrong. But this is what we understand. And that's why I wanted to take us back to history very quickly, because of the previous SARS viruses that we've had, and where they always have come from other animals and jumped species.
But it's a good sort of base for us to get a better clarity, and which has been done by you so well. Thank you very much for that. So I'll just go forward to say, we have done a lot of learning, like what you explained us over the last 45 minutes on what it is, how it is, and everything else.
Yeah.
So we are slowly heading, even though we are creeping towards it, we are heading towards going back to work and trying to achieve a new normalcy.
Yeah.
I can imagine, the regulations are something that's to be dealt with the regulatory bodies. So there's no point in us pondering about it. There's so much assumptions going on, and I would leave it for people to keep assuming till a protocol comes up. But for us, what would be interesting as professionals is how all these happenings in the last 2 months are going to make certain changes to us as professionals. With regards to our work environment, with regards to our family lives, our interactions, our social handling, and things like that. What is your perspective about it, Darshan?
So my perspective on it is, yes, obviously we are going to have a lot of changes. We've actually seen that, right? I mean, it's all our perspective, I'm sure, now, because of the last 6 or 8 weeks that we've had. You can see my current slide where it is telling us how life in general has changed for all of us, how much more organized we needed to get, how much more pre-planning we needed to do about our shopping, about work, about life in general. Everyone around us had to do this. And I think as a nation, we've done very well. But yes, there have been a lot of infections. There have been a lot of cases, but I think overall it's been an eye-opening thought process. Yes, environmentally we have been affected. Yes, we know that our living ways are probably going to remain the same until a virus vaccine has been created, or we have a medication that helps control the virus. There's a lot of research going on some retrovirals that supposedly does help improve symptoms. There's also some talk about chloroquine, but we don't have any clear evidence on it. That's why I didn't want to go down the medication route. But yes, dentistry in general is going to change, and we do know about that. There's some questions which I'm just seeing. I thought I'll quickly answer that. I won't take too long. Do you have a fit test before? Sorry? All of us will need to have a fit test done for the FFP3 mask, ideally Rajshri. Without the help of a fit test, your FFP3 mask is not going to be very helpful. So what we might have to end up doing is training there will be an online course, I'm guessing, where we can one of us learns how to do the fit test. Then we do the fit test for each other in our own clinics. And once we have fitted it, we should be ready to go. About the vaccine, yes, I read a lot about the virus. I really don't know too much about the vaccine. We do know generally that with FDA approval in the States, and for us to get approval here, the vaccine will have to undergo quite a lot of testing, and it will have to be tested for a period of time over different groups before we can say that it is safe enough for public use. because all you don't want is to create another problem whereby there's a, like how the MMR was discussed with autism, even though that was completely not true, there's certain things that we want to avoid. So therefore, the research that will have to go into vaccines will be time consuming, if not anything. So I'm not sure if we'll ever produce a vaccine by this year, end of this year, or probably early next year. Okay. I hope that answers your question, Sashir.
Yeah, so anything especially to do with what kind of PPE we are going to be going ahead with,
Yeah.
probably because there are listeners from different countries.
Yeah.
I think it's more or less a job of their particular regulatory body to decide what kind of a PPE they would propose and how they want to implement it. And it might change from geographical place to a geographical place. For instance,
Precisely.
for listeners from the UK, I think there will be a consensus between the Public Health England, along with the CQC and the NHS and all the other guys put together to come up with a proper regulation on what the PPE requirement is and what the protocols are. Does it make sense, Darshan?
I totally agree. I think it varies a lot from country to country, definitely the case. Also, we want to produce work where we want to be able to do work in a very safe environment, which is safe for us and safe for patients. And our standards are really up there, and I think we will, and the government and the country will try and keep it there to kind of make sure that we are safe and patients are safe. But we have some idea as to which way we are going based on, for example, what I showed you, what was there in the hospital, along with what the UDCs are using now, whereby I just have a small video clip, which is about 4 minutes, to just give you an idea. Well, right now with dentistry as such, we all know this anyway. We are reducing the aerosol generating procedures. We're referring on to UDCs. We've got the AAA concept that we're using now to help control the problem patients, the patients with dental problems. You've got the referrals to the UDCs that sometimes, depending on the area, has been quite difficult to do. There's difficulty in receiving treatment for patients. A lot of patients do call back and say they haven't received treatment as yet, or they're waiting. Obviously, the UDCs are inundated because there are not enough UDCs to the number of patients around, especially in the London area. And overall, there's just been a general idea that their patients have got a very poor satisfaction regarding how much cover that we've been able to provide for them, especially from a treatment point of view. I think generally patients are very happy about the feedback we're able to give them over the phone, but because they're expecting physical treatment, unfortunately, that's not being provided, and that's difficult to be provided now. But let's run through a very quick video. I hope this runs. I'll try and do this, and we should be able to see.
You need to get.
Sorry.
You need to get your laser off.
Okay. Let me try that. Yeah. And yeah, let me run this, and just shows you an idea as to how the PPE runs, how the UDC runs in the Yorkshire area, which is a very decent video of it. I don't know if you guys have seen it before. It has been making the rounds.
We start to look like airports, man.
It is, unfortunately. That's how it's going. That's an important point. Hmm. Hmm.
If someone wishes to take some screenshots, probably they can do that as well. But I think it's
yeah,
available on the YouTube anyways.
Yes, you can watch it.
But while they're watching it, I thought I might ask you a question.
Sure.
Darshan, this is again question from Dana. And Dana is saying, I'm still surprised that dental professionals didn't have a big spike in COVID cases, considering that we're still using AGPs almost up till lockdown. Lockdown. It doesn't fit in somehow. So that's more or less a debate that's going on as well. That we have been doing dentistry in the same speed as we were up to the 23rd of March, and then we haven't actually seen any kind of a clusters coming out of a dental surgery environment. Is there any sort of rational answer for that?
It's a very good question. That's exactly what I wanted to discuss. I think it's almost done, and then I'll answer that question actually. So, one second, sorry. I'm just trying to bring you back to where we were. Right. Okay, we're back on. That's a good point, actually, Dan. So I can see what you mean about not having enough number of dentists who have been infected by the virus, and I really don't have a straightforward answer to that. I really don't know why there hasn't been an increased number of cases. But this is what the government understands regarding the virus, even from places like China and Singapore, I think, or South Africa or South Korea. There have been papers to show that dentists haven't actually suffered increasing number of infections, and also that so there must be something that is missing in the picture overall. Having said that, our understanding is of the virus and how it infects us and how it spreads in aerosol producing in aerosol producing procedures is high, and our understanding is what it is now, and based on that is what the government's policies have come about regarding stopping us. But your question has got a very valid point. But unless there's another theory behind how the virus spreads and how it can be, right now we are not able to, directly question this. Hence why the lockdown, and hence why we are not actively working or actively doing any procedures right now. But it's a valid point.
Yeah, it is, isn't it? It's about starting to make this thing. It was amazing. So that's your PPE guidelines for the UDC setting, isn't it?
Yeah, this is pretty much like a picture of what we saw before. It's pretty much runs through that on a table, and also there's some of the colleagues tend to find that they use different PPE for different procedures. For example, when you saw the patient walk in, and the nurse who was greeting them didn't have a full set of PPE on. She had a head gear and the visor and the mask, and because she wasn't contacting the patient too much, the procedure of taking temperature, was not of a particularly high risk. So the kind of PPE worn was something like that, as compared to when you are providing a procedure where you're doing an extraction or you're using when you're producing aerosols, and the level of protection suddenly increases because you've got these gowns that are coming all the way up to the elbow, the gloves that go over it, so there is a seal there, and apart from the neck being exposed, you have a headscarf and the acetate, what you call the visor, along with the close adaptation onto the forehead, so nothing escapes in, and the eye protection secondary to that, because of the potential chance that you get a transconjunctival infection source. So that's what we will be doing. Yes, we need to still wait for the guidelines. You change the way we work every day. As you heard, the particular UDC that we were looking at, they needed to have triage rooms. They need to have a separate donning and doffing station, although the doffing station could be inside the surgery that they're treated, if they do not have a third room to be able to go into. Treatment trolleys, where you can't leave any instruments inside the surgery. Everything's on a trolley, gets taken in for that particular treatment, taken out straight into the cleaning area. They also talked about the time that you need between treatments, which is approximately about half an hour, to be wiping all the surfaces with a chlorine-based disinfectant. And you see that the amount of manpower that goes into treatment, the amount of treating a single patient, the number of people that you would need, the amount of time that is required has greatly increased. But having said that, I am someone who always looks at a cup half full. So for me, I'm thinking that we will become more slick as we go along with the new system. When the CQC came in and the new regulations came in, we struggled a little bit initially to adapt to it, but we did. Now, most of the practices that the CQC reviews are compliant. In the same way, I think we will be compliant with these new regulations as well. But regular testing will become a necessity, as someone was pointing out before. If you get an antibody test and you have the antibodies because you've had the infection before, then, and if the patients, and this is something that we'll be asking, like how we ask for hepatitis B assays for patients or for staff when they join to work, we could be asking patients as well regarding their tests for corona. Then there's a focus on infection prevention and control as the services broaden. And this is what generally the NHS or private dental staff will need to recover and improve before the whole thing can come together, which I think we will. So the future, yes, we were looking at something called an R number. I think everyone knows this already. For the ones who don't, I'll explain it very quickly. It's when one infected person gives the virus or the infection to another person. If it is less than one, then they're infecting less than one person around them, which is ideal. I think when our Prime Minister, when he, on a Sunday, I think last Sunday, told us about easing the stages of the lockdown, it was basically on the fact that the R number had just come below 1, especially in London. But I think now we're not sure. I just read something yesterday in a paper that the R numbers might be creeping back up again. We're not sure about that. We discussed about the stage in the lockdown where we were trying to reduce or cut down the spread of the infection completely by doing the hand washing and the masks, which are, again, very difficult to tell as to how much it prevents infections depending on the type of the mask. And then we could go up to the test, trace, and isolate. So we are testing stages now. And then eventually, fingers crossed, we'll come up to the vaccination stage. So that's pretty much what we've been discussing.
That was very, very nice and detailed. That was amazing. I hope all the participants today have loved this debate as much as I did. We can take some more questions with regards to this topic. But before I start asking a few questions, let me just update all the viewers about what's coming. The next one is amazing. This is on the 21st of May, that is this Thursday, and this is on guided bone regeneration and other current concepts of bone and soft tissue manipulation. Okay, the speaker is a very well-renowned international speaker. He's also a diplomat for the ICOI. Dr. Tarun Kumar is very, very well-renowned everywhere. And bone regeneration, Darshan, you can tell me if I'm wrong. Bone regeneration, soft tissue management, extractions, implants, these are something that's going to take high precedent as we go back, because a lot of these can be done with minimal amount of aerosol regeneration. And there are certain procedures or processes by which we can even do surgeries like implantology by using slow drip technique and by using other mechanical devices, which will be run down in the program as we go forward. So guys who are interested in bone regeneration, soft tissue, it's a wonderful topic of discussion that will come on the 21st of May, exactly the same time, which is 3 o'clock. We will send you details about it. With regards to the CPD, you got to just go to the website, and the same button you press to get started will show you a multiple choice question button. If you fill that up, fill your feedback, you should be able to download your CPDs. However, apologies, there is a bit of an issue with regards to downloading the CPD certificates. Don't worry about it. We have the records. As soon as the problems are resolved, you will be emailed with the links. So don't worry about it at all. We will keep you updated on that. So with that note, a very, very, very big thank you for Darshan for taking all the time and explaining it with so much patience and with so much passion. This is something I love about Darshan all the time. Whatever he does it with so much passion that we just fall in love with what he says. So I'm really, really happy that we did it today. Going further, I would really be happy to see if anyone wants to take some questions, but also I want to thank Dr. Senthil, who's on the screen now, and Dr. Jay. These are the guys who are doing all the hard work behind the screen to bring everything together. So any problems, give us a shout, and they're gonna make sure, and also your feedbacks. We have really, really worked very hard on your feedback since last time to make sure it is very interactive, to make sure it gives you all the things that you're sort of looking for and the information you're looking for. So please give us as much feedback as possible. You can either email us, or you can WhatsApp us or text us, and we're gonna take that up very seriously and make sure that will happen for you. So that's the message from all of us at Dental Routes. If there are any questions, Senthil, is there? Okay, there is a question from Dr. Manjunath. Hello, Manju is one of my very nice friends whom I know from a long time. So what his question is why Asians are more affected? I think he's looking at the numbers that he's seeing in the UK statistical market. So what do you have to say about that?
I really don't know why Asians are particularly more affected than others. It must be a multifactorial thing, but we must understand that in an NHS point of view, in the UK, from an NHS point of view, a lot of frontline workers are from the Asian subcontinent, further Filipino and further Eastern backgrounds. So hence why, if there's more patients, more people working there, and obviously they're getting more exposed, and therefore they might be more prone to getting the problem. It also has to do with probably as to how fit and well they are, what age level they've got exposed at. So it does vary a lot because that's probably why we see an increase in numbers, but there's no direct reason why. I'm sure that it must be multifactorial.
Yeah, I think so. Yeah, I think, and especially in the UK hospital section, we have a high number of people working from the Asian background. If that's right,
yeah, that's right to some extent. Yes, depends on which area and which hospital you're working in, but generally, yes, that's pretty much the truth.
Lovely. So wonderful. I think we had a wonderful session today. Thank you very much, all the viewers, for tuning up and be so patient and helpful, asking your questions, because that is what keeps us going. That is what makes us work extremely hard. Have a wonderful evening tonight, and we will really look forward to see you on the 21st. It's an amazing lecture again, and we will catch up, everyone. So
I just had one thing to say. I had to thank two people. I need to thank Nick, who helped me out with understanding a lot about the ventilators. He's an anesthetist. And also Deep, who's a colleague of mine, who gave me the link for the videos. Yeah, so thanks a lot for that.
And I thank you, Darshan. I thank you very much for an amazing webinar today, and Senthil and Jay for your help. I also want to thank Karthik, who's our web support. Without him, it wouldn't have been possible to run things so smoothly. So thank you all. You're a wonderful team, and we say goodbye for today. Enjoy your evening.
Thanks,
Thank you, guys. Thank you.
Thank you.
Bye.
See you soon.
Bye-bye.